So I first did clinical research with SLT starting back in 1996 when working with Mark Latina to help perform the first U.S. clinical trials that led to approval of SLT in the United States later on. So basically in the mid-90s we started developing clinical experience. We worked together to develop treatment algorithms and measure clinical performance. And then also I started doing some, at that time, some histopathology studies evaluating the effect of the laser therapy on human tissues as well as animal tissues. So some lab work approximately in the 90s as well. So a couple of the studies that I've been involved with in terms of laser trabeculoplasty, the first was once again the study that led to the clinical trials, kind of the first clinical study ever done with SLT, where we were looking at making a comparison of treating SLT in patients who had never had maximum molecular therapy but no prior laser trabeculoplasty, or who had failed prior laser trabeculoplasty. And basically those patients were treated. We looked at the clinical outcomes and found that they were favorable. And once again, this clinical study led to FDA approval. Also did kind of landmark histopathology studies comparing SLT to ALT, which I think many people have seen the scanning electron micrograph photographs comparing the two studies, which I really think help substantiate the safety profile of SLT compared to other forms of laser trabeculoplasty. And then more recently, the SLT med study, which was completed several years ago, I think is really the most modern comparison of treatment algorithm. And that study looked at using a modern treatment algorithms of medical therapy, using prostaglandin analogs, etc., comparing that to using SLT as a primary study in the treatment of patients who are newly diagnosed with glaucoma. And patients were randomized to either a medication arm or the laser arm. And the SLT med study really helped, I think, form what we do in clinical practice these days and guide it, as it showed that SLT was a very reasonable treatment for first-line glaucoma patients. So the Lumenis selective SLT is probably one of the most important things that I have in my practice. I certainly use it to treat patients who are new to glaucoma therapy, so patients who have never used anything are either newly diagnosed, ocular hypertensives, or early glaucoma patients. It's also a nice alternative for people who have already been treated and either they need additional therapy or they're having problems with their current therapy. Maybe it's tolerability issues, maybe the medical therapy that they're using is not good enough, but it's really nice to use in that population as well. I've used it even in patients who've had prior glaucoma surgery and now just need a little additional IOP lowering to get them at an adequate treatment level to stop them from getting worse. So the nice thing about SLT is it's very diverse. So I find it an essential tool in practice and I'm glad I have it.